Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. The patient in this procedure attended with bilateral, so when we say bilateral we mean both ears, otitis externa. Otitis externa is an umbrella term given for an infection and or inflammation of the outer ear canal, and we are just in the left ear here, and you can just see that the ear is very wet, there's a lot of discharge, the ear canal is also swollen, so there's a lot of edema, swelling, particularly near the entrance of the ear, the outer third, the cartilaginous portion. And we have this bit of earwax, but also what we call otter ear. So otter ear is the medical term given for ear pus, basically, ear discharge. And I've cleared the occlusion. So when we clear the occlusion, an occlusion is something that's obliterating, blocking the ear canal, preventing sounds and air from travelling through the ear canal up to the eardrum. And in this case, that blob of debris wax, that was the occlusion. So I've cleared that, but my main task now is to try and remove as much of this infection, dead skin off the ear canal as possible. I was fortunate enough a few years ago to work very closely with a good friend of mine, who I'm still good friends with, my other previous co-founder of Clearwax, Mr Stephen Darius Rajali, who's an ENT consultant surgeon. And I, in a way, worked and shadowed him for quite a while whilst we were developing the endoscopic earwax removal procedures in the UK and promoting it. And being an ENT surgeon, they obviously have very complex clinics, and I used to attend, I think, let me just get this right, 4 clinics a month, and it was so invaluable. I don't do those clinics as much now just because I'm so busy. Not that I wasn't busy before then, but it was a useful education for me, and quite often we will deal with patients with otitis, as opposed to the day-to-day earwax removals. I used to treat a lot of ear infections, and one of the things that we try to do in this specific clinic, and it obviously depends on your experience and skill levels, but is to remove as much debris as we can. Sometimes patients don't respond very well to medication for ear infections, and it can be chronic, but one of the things that can help an ear infection resolve is just trying to clear the ear as much as possible, allowing the infection to your ear to fight against the infection, and any drops or ailments that you use to penetrate the surface of the ear canal and the eardrum directly. When you've got all this pus and dead skin and debris, it doesn't allow the maximum efficiency for these medications and ailments to work. So what I'm doing now, I'm just using a fine end gauge, and I'm just trying to remove as much dead skin as I can off the eardrum. Now the eardrum itself, you can't really visualize any landmarks because it's also inflamed. It's just red basically. You can't see the hammer bone, the umbo, there's no light reflex. You can't see the handle of malleus, which is so the hammer bone, you get 3 parts of the hammer bone that are typically visible an unhealthy ear. That's the umbo, which is the centre part that actually adheres to the centre of the eardrum. You then get the handle of malleus, which is the long, another term for that is called the manurbrum. And then you see what's known as the lateral process, or the short process, which is the top part of the hammer bone, which kind of protrudes outwards more or less. So I'm just on the roof of the ear canal. You can see this ear canal is very swollen, actually even very deep in the ear. There's a lot of soft tissue there, and I've just got this keratin that I'm just trying to peel off the roof of the eardrum now. So that is the eardrum that we're working on, or just above the eardrum on the roof of the ear canal. You can see all this dry skin, flaky skin near the entrance, and as we get further in the ear it's a lot more wetter. So after completing this procedure, we sent the patient's GP a referral so they can administer the required medication to help treat this ear infection. So this is the left ear. We also are doing the patient's right ear, which will be following this procedure, is also slightly infected. You can just about see the handle of malleus there. Actually, it's travelling from say 11 o'clock towards 5 o'clock, just on the top of this suction probe where I am now. So it's very red though, it's very inflamed. And so we've still got some debris on the anterior superior quadrant of the eardrum and ear canal, which is another, we could just describe that also as the northwest, where I am now with the suction probe. Because the ear is very narrow, due to the swelling, obviously it's difficult to sometimes access all regions of the ear canal, but I think that's one of the benefits of an endoscope, because of the endoscope, it's the field of view it provides. So when performing procedures in ears, there's many different visualization techniques one can use. You can use head loops. Head loops are magnifying goggles, essentially, similar to what dentists use. The limitations of head loops, I'll come back to that moment. You can just see here, I'm just gently peeling this dead keratin out from left to right, and it's just got tangled at the base of the eardrum, but I'm just going to loosen that and then bring it forwards. Head loops, and that's what I originally got trained in 5 or 6 years ago, or probably a bit longer now, 7 years ago. The problems with head loops, so everything's got pros and cons. With head loops, they're portable, small blueprint, it's not like an ENT microscope that weighs a ton and takes up a lot of space. So you can see the eardrum there, so it's all visible. So that's the left eardrum, just going into the right ear. It's, again, the right ear, there's a lot of debris there and it's also infected. So I'll just let you watch and I'll just continue explaining the different visualization techniques. So head loops, yes, are similar to what dentists use to examine inside the oral cavity, the mouth, and sometimes down the throat. Problem with head loops with the ear is that you lose focus very easily. So one slight movement of your head, of the patient's head, and you lose focus. Even with the very best loops that I did invest in some, just the magnification's it's not great, and you lose your depth of magnification. So earwax that's very lateral near the entrance, fine, not a problem, but when it's deep in the ear, it's almost like it's a blind spot. And for that reason, I decided no longer to continue. I didn't feel that it was adequate. It's been advertised that also loops, one of the advantages are that it provides you with what we call depth perception via stereoscopic or binocular vision. That's not necessarily the truth with loops. To enable depth perception with using binocular vision, so both eyes must be able to visualize the piece of earwax in the ear canal. That's virtually impossible with standard head loops because the ear canal is too narrow. You may be able to do that if the wax is lateral, but deep in the ear, in order for both eyes to visualize the earwax deep in the ear, you must have a really, really short, what we call interpupillary distance. So the distance between both pupils, eyes, must be able to converge and look at that point deep in the ear, which is not possible. But there are other types of head loops called the Endoscope, where they artificially converge your eyes so they are together, a bit like a periscope in a submarine. However, the magnification on those are still a bit not always adequate. So head loops for me, even with these latest ones that are available from Brotech, which do converge the eyes artificially, like a periscope, to give you that depth perception. I don't, because of the lack of magnification with those ones, that's the limitations. But some people get on really fine with them, and I think I always advocate people to use what they feel they're most proficient at. So the next level up, I would say, from head loops and even these converging magnifying goggles is an operating ENT microscope. So that was the gold standard, really, up until about 20-30 years ago, where endoscopes are starting to be used for endoscopic ear surgery. So the main benefits of a microscope is that you do get that binocular vision, because they do artificially converge your interpupillary distance to converge at a single point deep in the ear, which gives you that depth perception. Magnification is fantastic as well. The negatives though, and this is also going back to Luke's, negatives with both ENT operating microscope and head loops is that it's a very narrow view of the ear canal, and the eardrum. You don't see the same view now. You only see a quarter of the ear canal and eardrum. So you're having to constantly move the microscope or the patient's head to get to visualize all different parts, and you don't see it all in once. So you're obviously having to, in a way, visualize one part of the eardrum, remember it, look at another part of the eardrum, remember it, and in a way picture a mental image in your ear. Now, for some surgery, I was speaking to Mr Rajali, ENT surgeon, and he said for some surgery he still prefers using a microscope, like for a mastoidectomy, but for other surgeries he's now tending to favour an endoscopic approach. But again, it's each to their own, it's what someone's most comfortable in. So with an endoscope, again, the main argued disadvantage of an endoscope is that you're viewing it on a 2D screen. So the argument is with an endoscope you don't always get depth perception. I would disagree. I think with experience you develop, so although you're not using binocular or stereoscopic vision to obtain depth perception, you're using monocular vision. So essentially using one eye, because both eyes are looking at one flat screen. So in essence, that's monocular vision. You can close basically one eye, and with an endoscopic approach, and it would be no advantage of almost having limited benefit of having two eyes, because you're viewing it off a single flat screen, if that makes sense. However, you do develop depth perception even with monocular vision with an endoscope, partly because of the view it provides you. You can visualize the old ear canal, the landmarks, the first, second bend, which gives you an indication of the depth, how far you're in the ear, shadows, and also when you move the endoscope forwards and backwards, that the difference in speed of the vision change of the ear canal compared to the eardrum, which is indirectly in front of you, also gives you a depth perception. We call that motion parallax. So I've quite often, you can see I might have been on the eardrum quite a lot on this procedure as well, so I've developed that. So and when we first introduced endoscopic earwax removal in the UK, there was the status quo, should I say, who were trying to talk down upon it. It was quite funny. I won't speak too much more about that, but there was some guidance issued a few years ago, really being negative on endoscopic, and we challenged that view, and it actually got redrafted based on that, and there were some apologies given to us. In any case, the right side, you saw that procedure. The otitis externa is more lateral, more near the entrance, more inner third half of the ear canal wasn't as affected. So, but there still is an infection, still this dry skin. It's eczema, psoriasis, whatever you want to call it. So again, the GP will need to be prescribed some medication. Eardrum nice and healthy. There was some impacted debris, dead skin, wax, and we managed to remove that. I used a fine end gauge and I bent the tip a bit to access the anterior recess, curling behind that. Just mopping up here. I hope you enjoyed that video, guys, and I gave you a bit of an insight on the different methods of visualizing the ear when performing clinical ear care procedures. I hope you're all having a good evening and you're all keeping well and safe. Take care. Bye.